Today, we'll continue to talk about ischemic heart diseases, and today we'll talk about myocardial infarction. Last lecture I said you ischemic heart diseases may be manifested with angina pectoris, which is short time constriction or spasm of coronary arteries, and more grave pathology myocardial infarction, which is characterized with formation of necrotic focus in the heart muscle due to upset coronary circulation. As you see on this slide, usually it appears of the patient with atherosclerotic affection of coronary vessels and prolonged obstruction of coronary vessels finish with damage and then formation of necrotic focus in the heart muscle. Etiological factors resembles etiology of angina pectoris. First of all, it is coronary artery atherosclerosis, which affect vessel, disturbed activity of this intima, and as a result, disturbed coronary circulation. We must remember about embolism coronary vessels due to endocarditis or septic thrombophlebitis. But we remember that atherosclerotic plaques also can be formed pathological thrombocyte adhesion, which accompanied with pathological process. And last problem, it is inflammatory affections of the coronary arteries, such as rheumatic coronaritis, obliterated endarteritis, or nodular periarteritis. It's more rare pathology. First of all, patients with myocardial infarction, there are patients with atherosclerosis of coronary arteries. If we'll stop on pathogenesis, initial period of myocardial infarction is characterized with ischemia because short-time obstruction of coronary vessels manifested with ischemic process into the heart muscles. Later, it's transformed in necrosis. After some times, around necrotized area will be inflammatory changes which usually finish with formation granular tissue. Other words, with formation of post-infarction scar, growth of cicatrial tissue. It is optimal finish of myocardial infarction with formation post-infarctive cardiosclerosis. More grave, if necrotic foci is wide and deep and insufficient growth of granular tissue, it will be very thin and significant in its size and will be formed cardiac aneurysm. It's a negative variant of the myocardial infarction because any excitation may be finished with rupture of aneurysm and death of patient as a result of heart tamponade. It explains you why first period of myocardial infarction, when the necrotic foci is formed into the heart muscles, will significantly, completely restrict physical activity of the patient because some movements can provoke destruction of the necrotic focus and all blood from the heart moves into the pericardium. We are talking about heart tamponade and death of patient. Next picture show you all pathological process about which we said you see health heart with normal coronary circulation, coronary vessels thrombotizated. A result will be formed first of all ischemic area, then damage of myocardium and formation necrotic foci. Each is optimal variant, formation of post-infarctive scan. Which is negative variant, formation of heart aneurysm. You see difference between post-infarctive cardiosclerosis and heart aneurysm. And negative variant, early damage of the myocardium with formation heart tamponade and immediate death of patient as acute complication. Classification of myocardial infarction. No, first of all, we distinguish macrofocal myocardial infarction, or other word with pathological Q wave, and without pathological Q wave, which is microfocal myocardial infarction. No, you understand that more deep and high size of the necrosis, then more negative and prognosis for the patient. And maybe short subendocardial myocardial infarction, sometimes it appears without significant clinical picture and patients seen about usual attacks of angina pectoris and not enters in hospital. Clinical picture myocardial infarction was described by Russian physician Obraztsov and Strazeska, you see, more than 100 years ago. But it is actual now. And primary will be distinguished three main clinical form of myocardial infarction. Classical anginous form, which resembles clinic angina pectoris. Asthmatic, when on the first plan will be attacks of dyspnea, and abdominal, when clinical picture resembles acute abdominal situation. Later, it will be widened, but now we also oriented on describe three primary forms. Classical anginous form, characterized with intensive compressive retrosternal pain, but on contrary from angina pectoris, it's more severe, sometimes may be sharp or stabbing, and oftenly accompanied with disordered heart rhythm, extrasystola, paroxysmal tachycardia, and other heart rate disorders. Provoke factors same as for any ischemic heart disease, which is physical or nerve excitation and poisoning with alcohol or nicotine. Pain irradiates upward to the left, about which we said last classes, but it cannot be removed nitroglycerinum more than 20 minutes, and patient take 2, sometimes 3 tablets nitroglycerinum, no effect, he immediately must call doctor because it may be myocardial infarction, because we remember usual attacks of angina pectoris immediately disappears after taking nitroglycerin. Pain may be long and sometimes needed specific analgesic therapy with using narcotic methods. If the pain during more than 1 hour, we are talking about status anginous, and it is grave for the patient because may be complicated with severe complications. On inspection, we see fear and excitation of the patient because any acute situation accompanied with reaction from central and vegetative nervous system. Patient complains of progressive weakness, then his physical activity decreases. We can see that skin of the patient may be pale with some bluish hue, covered with cold sweat, and will record decreased blood pressure. If the blood pressure lower than 70 millimeters hydrogel for systolic pressure, we are talking about cardiogenic shock. Because we remember, shock is acute vascular insufficiency, which characterized with fast and significant decreased blood pressure. On auscultation, we cannot feel sound or both heart sound because decreased activity heart muscle, decreased muscular component plus decreased blood pressure. Sometimes we can reveal gallop rhythm, which is characterized with weakened first sound and audible vibration during diastolic filling of the heart with blood. May be revealed any types of arrhythmia about which I said you. Blood pressure may be increased primary and then falls. Sometimes high blood pressure may be provoke factors of myocardial infarction, about which we will talk later. And over the lung may be revealed moist trails as the acute early complication as acute left ventricular failure. We remember, first of all, it is characterized with cardiac asthma and then lung edema, and will have moist trails over the lung. Asthmatic form, which is a typical form. When the patient first of all feels problem with breathing and pay attention on breathing, call the doctor due to attacks of dyspnea, and sometimes doctor can think about bronchial asthma, especially if the patient has in anamnesis bronchial asthma. But we know about some differential diagnostic symptoms and lung auscultation, which will be different for cardiac and bronchial asthma, because in our case, it is early complication, appearance of the left ventricular heart failure, which manifested with cardiac asthma, and then very fast transformed in lung edema. Abdominal form is characteristic for the patient with low side location of myocardial infarction, and due to crossing innervation, instead pain in the heart, patient feels severe pain in abdomen, in epigastric region. Sometimes it's accompanied with nausea, maybe diarrhea, and you see on this picture, and as a result, patient may be hospitalized in infectious department with acute infectious pathology if prevalent vomiting and diarrhea, or in surgical department if prevalent pain in the abdomen. And to exclude any mistake, all patients with acute abdominal pain obligatory must be sent on electrocardiographic examination. New form, which will be described after Obraztsov and Straževska later, which is collaptoid form, when the pain in the heart region absence, but patient suddenly feel giddiness, blackout in eyes, weakness, and man lost consciousness, will record drop blood pressure. Sometimes we can see, if the doctor not completely oriented, he can think about usual syncope and not pay attention on possible pathology of the heart. Edematous form, also manifested with sudden dyspnea, weakness, palpitation, different types of arrhythmia, and pronounced edema. But it is more characteristic for the patient with preceded long-standing pathology of the heart, which has chronic heart failure, and sometimes due to affection of coronary vessels, together with chronic heart failure, will be state of myocardial infarction, which accompanied with acute heart failure, when the symptoms of heart failure becomes more pronounced, especially edema. Arrhythmical form is characterized with different types of arrhythmia, from extrasystole to paroxysmal tachycardia and atrial fibrillation, but pain syndrome insignificant and sometimes may be absent. And again, doctor, pay attention on arrhythmia, not attentively see ECG, and can miss myocardial infarction. As a result, it will be finished with death of patient. Cerebral form, when on the first plan will be signs of the disordered cerebral circulation, such as headache, nausea, vomiting, sometimes deranged consciousness, but again, it must be correlated with blood pressure or with pathology of the heart. And again, I'll remember you why is needed examine patient completely, especially if you see patient first time. And more easy low grade form, when the painful syndrome absent or such weak that patient can see about usual attacks of angina pectoris. Usually it is insignificant affection of the heart muscle without formation of necrotic foci, or it's very small and not deep, and such form of myocardial infarction usually treated ambulance form, and sometimes patients are known and informed about myocardial infarction after some years due to casual case of ECG examination. Diagnostic principles of myocardial infarction. First of all, we'll pay attention on ECG because it is main method for diagnosis myocardial infarction. It helps clear depth, width, location of the necrotic foci, distinguished form, if you remember, with or without Q wave. Later, we can send our patient on ultrasonography to clear post-infarctive complications, to assess activity of the heart contraction, depending of the heart stroke, and reveal degree of the heart failure. Laboratory examination, no obligatory usual blood analysis, and will obligatory examine specific marks of the heart necrosis, such as C-reactive protein, myoglobin, LDG, LT, ST, and I'll pay your attention on troponin because it is main index for diagnosis of the myocardial infarction, because when the patient enters in hospital with acute retrosternal pain, primary diseases may be formulated as acute coronary syndrome. And then after ECG examination and examination of troponin, we'll do differential diagnosis because prolonged attacks of angina pectoris or myocardial infarction, and principles of treatment will be different. We can send our patient on coronary ventriculography, especially it is needed for deciding tactic of treatment. It will be with usual therapeutic measures or needed transplantation of stent, about which I said you last lecture. ECG is main method of diagnosis. I said you it helps clear stage, localization, depth, size, and location of myocardial infarction. And depending of ECG, we distinguish three period developments of myocardial infarction: initial ischemic, then ischemic damage, and final necrosis. And Then later patient will be examined that more deep changing of the heart will be revealed on ECG. For example, if we'll examine patient first minute, no, first hour after attacks of pain, we can reveal it on initial stage on ischemic or ischemic damage, and then early will start adequate therapy, then more effective will be our treatment and good prognosis for the patient. If the patient will be examined later after 2, sometimes more hours, because patient wait since that pain disappears independently or emergency aid cannot be in time, we can record ECG on the stage of necrosis, when the heart muscles died, and you understand it will be finished with formation of scar, and then more wide and deep necrotic forces, and more sick will be post-infarctive scar, and then more grave chronic late complications. How can we know about a stage period of myocardial infarction? Depending of specific indices, and if you remember first classes of ECG interpretation, we said with you about 3 main indices which are marked of the myocardial infarction. There are T and Q wave and position ST segment. Ischemic signs of myocardial infarction, which is changing T wave, which becomes sharp, symmetrical, high, maybe positive or negative. If we reveal such T wave of the patient with heart pain or other atypic form of myocardial infarction, we think about ischemic process, which is initial stage of which without adequate treatment may develop and finish with formation of necrosis. You see normal rounded asymmetric T wave change its polarity and shape, which is initial ischemic period of myocardial infarction. If the process progresses, next step will be damage of the myocardium. Damage of the myocardium, about which indicates position of ST segment, which rises or displays above isoelectrical line. Normally, if you remember, ST segment must be compared with TP segment, which must be on same level. It must be isoelectrical. Due to damage of the heart muscle, ST segment moves up. What? With formation pathological cardiac. Or we are talking about elevation ST segment, and if you see on ECG elevation ST segment, your conclusion will be about damage of the myocardium, ischemic damage of the myocardium, progressive stage of myocardial infarction. You see as normal isoelectrical ST segment rise upward. And if you see on this ECG, no problem with first standard lead, but in second standard lead, ST segment, and third standard lead, ST segment rise upward, which indicates about ischemic damage of myocardial infarction. And during this period, we cannot say about angina pectoris. It's not characteristic for attacks of angina pectoris. And necrosis. Necrosis, when the heart muscles die, about which indicate pathological deep and wide Q wave. We remember normal Q wave very small, its depth cannot exceed 1/4 R wave. Sometimes it's invisible, or if you see deep widened Q wave, we are talking about myocardial infarction, about necrosis of the heart muscles. Sometimes if the necrotic foci is deep and wide, as the word contraction of heart muscles impossible this area, our wave becomes unvisible. We are talking about pathological QRS or QS complex. Because R wave indicates about heart contraction. You see normally R wave nearly 10 millimeters. It diminishes if the heart contraction decreases, and if it's impossible on some areas, R wave becomes unvisible, and we are talking about pathological QRS or QS complex. You see heart muscles die, and on ECG will be recorded pathological QS complex with elevation ST segment acute period of myocardial infarction. Area of necrosis very significant, and it's not contracted. You see contraction outside of them, and this side not recorded RV. Let's see dynamic developments of the acute myocardial infarction with Q wave, otherwise with deep necrosis. Now, you see on this slide, first of all, normal ACG when ST segment isoelectrical, T wave rounded asymmetric, and Q wave unvisible. Patient calls the doctor due to pain in the heart region. We are talking about formation ischemia, T wave change polarity, becomes sharp, and then later we'll see it becomes more and more deep. Later, ST segment elevated, we are talking about formation of ischemic damage, and we see pathological deep and wide Q wave as index of necrotic zone. Depending on correlation, these indices T, ST, and Q wave will differentiate clinical period of myocardial infarction, depending on which will prescribe some regimen for the patient. Acute period, when the process progressively intensifies, needed strong bed regimen. Subacute, when the pathological process stops and develops backward. We are talking about formation of granular tissue. And final period, when will be formed post-infarctive scar, and patient may be discharged from hospital and come back to his usual or restricted life, depending on the depth and size of necrotic foci. You see, as far will be formed necrotic foci, only ischemia, which is first time before 1 hour. After 3 hours will be damage, and then formation necrotic foci. And if our patient will be examined 1 day later from the beginning of the pathological symptom, we see formation deep and wide necrotic foci. It shows you why. Then early will start examine patient, clear disease, and start adequate ethiopathogenic treatment, then more good prognosis and more full life will be for this patient. Acute stage of myocardial infarction. Process progresses. Is characterized with formation necrosis zone. It may be slowly or more fast. Obligatory presence of ischemic damage and ischemia of the heart muscle. I'll remember you, it depends from time of the patient examination. Early, only ischemia. Slightly later, ischemia plus damage. Later, all symptoms will be revealed. But you interpretate ACG on exam depending more heavy process. If you see damage and necrosis, your conclusion will be about necrosis. If ischemia and damage, your conclusion about damage. Ischemia manifested with coronary T wave. Ischemic damage will see elevation ST segment, and necrosis manifested with formation pathological Q wave or QS complex. Acute stage. Patient needed strong bed regime because any physical activity may be finished with heart tamponade, about which I said you later. You see ischemia and damage, then damage more intensive and we see formation of Q wave because necrotic zone, necrosis progresses, we see pathological QS complex. Result your ECG depends from time examination of the patient from beginning of pathological symptoms. Subacute stage shows that process come back. First of all, on ECG will be sign stabilization of the necrosis zone. As result, will be gradually disappearance of ischemic damage, because you understand necrosis may be after damage. If the damage stop, also not following necrosis. And ischemia of the heart muscles will be halt because process not completely finished. How can we know about stabilization of the necrotic zone? Depth of Q wave or QS complex not progresses. Ischemic damage disappears because ST segment gradually come back and after some times becomes completely isoelectric. And T wave hold its ischemic characteristic. Patient with myocardial infarction will record ECG continuously all time of his hospitalization, on time of strong bed regimen and doctor control. And if he compare yesterday and today's ECG and sees that elevation of the segment diminish, next day more diminish, next day completely isoelectric, we said about subacute stage will widen the patient bed regimen. He can get up from the bed, can go along the ward, we can widen his dietary regimen and other treatment manipulation. Patient with a subacute period, you see period of necrotic foci, which characterized with deep Q wave or pathological QS complex, and ischemic zone, negative coronary T wave, but you see no damage of the myocardium ST segment, completely isoelectrical. Primary, it was right, but will control position of ST segment every day and wait when it completely becomes isoelectrical. It shows about subacute period of health. And last cicatrial stage, when the growth of granular tissue finish with formation of post-infarctive scar. This patient may be discharged from hospital. How can you know about formation connective tissue? On ECG will behold only pathological Q wave. ST segment isoelectrical, T wave losses its ischemic characteristic. It may be negative, flat, positive. It depends from size of the cicatrial scar but it will be assessed as disturbance repolarization because it loses its ischemic properties. We remember ischemic T wave must be sharp, symmetrical, and high or deep. If you was attentive, you see development of the myocardial infarction at the beginning, continuously, T, S, T, Q. Comeback development, first of all, disappears as T, then T, and we'll see patient only with pathological Q wave. And if you see ACG only with pathological Q wave, we must ask him about possible myocardial infarction anamnesis and assess it as post-infarctive scar. You see ST segment isoelectrical, T wave negative but it's rounded without ischemic characteristic and will record only deep Q wave. Such ECG will be assessed as post-infarctive scar. More grave if our patient with formation of heart aneurysm. How can we know about it? Depending position ST segment. It moves downward, but after some days stop on same level and not completely come back to isoelectrical line. We'll send our patient on ultrasound examination and see formation aneurysm. Patient also will be discharged from hospital, but I explained to you any overexcitation may be finished with easy rupture of thin connective tissue and death of patient due to heart tamponade. You see normal, yes, we see damage and you see aneurysm. Thickness of the wall significantly different from normal heart. And you understand this patient cannot come back to his usual life. No active work, no active physical exercise, restricted emotional situation. No, to finish. Interpretation, I'll again pay your attention on ACG. Normal ACG. We remember three pathological indices, Q wave, ST segment, and T wave, which will first of all examine if you think about possible myocardial infarction. Sharp symmetrical T wave, ischemia, elevation ST segment, ischemic damage, deep Q wave necrosis, deep necrosis, pathological QS complex. Then ST segment gradually go backward. When it becomes completely isoelectrical, we are talking about subacute period, growth of granular tissue, we see pathological Q wave and ischemic T wave. And when T wave also loses ischemic properties, ST isoelectrical, T wave abnormal but not ischemic, and accompanied with deep Q wave, we are talking about cicatrial period, patient health may be discharged from hospital. Health from acute myocardial infarction. Depending on location of these indices, we differentiate position of myocardial infarction. For example, if it localizes on anterior wall, we'll reveal pathology only maybe first standard lead, but first of all, we 1, 2, 3, 4. If the anterior lateral will reveal pathological process, we 5th and 6th and obligatory anterior wall of the heart. Diaphragm lower myocardial infarction, characterized with pathological indices on 3rd AVF and V5, 6 chest leads. You see, it is acute period because deep QF and elevation ST6. I said you about laboratory examination. You see, biochemical indices may be revealed after some hours to some days, sometimes maybe hold some months. But I Again, remember you first of all will pay attention on troponin, which is gold standard of myocardial infarction as biochemical marks of the myocardial necrosis. Usual common blood analysis will reveal leukocytosis and acceleration ESR, but after some weeks, leukocytosis disappears, but elevation ESR may be held during 3-4 weeks. Again, all depends from the size and depth of necrotic foci. Principles of treatment. No, I said you, then early will be established disease and patient will be hospitalized, then better will be for him. And first of all, absolute rest regime. Will hospitalize patient only on the stretcher card. Patient can say you, I can go. It's impossible because any physical excitation may be complicated with immediate rupture and death of patient. Rest must be absolute. Why? Because it's not includes only physical restriction. We must restrict diet of the patient. It must be low calories. Maybe food must be easy assimilable, which not needed active blood flow to gastrointestinal tract. Light diet. And principles of our treatment, first of all, as possible early, we must remove pain because it may be provoke fracture of cardiogenic shock, early thrombolysis therapy, and then any symptomatic treatment depending on complication, early or late complication. We must control cardiac rhythm, we must prevent formation of acute heart failure and any other complication. No, complete treatment you will study on the next courses. Now I'll give you information only that for your general orientation. Now, if you want check yourself, you see graph. First of all, for yourself, see what is it, ischemia, damage or necrosis. If you think about necrosis, it is true. If you see on this graph, it must be assessed as ischemic damage. And next question on which I want to stop today, it is examination of the patient with arterial hypertension or hypertensive syndrome. Now, first of all, to talk about arterial hypertension, I want to remember you. We'll measure systolic pressure, which depends from heart stroke. We'll distinguish diastolic pressure, which depends from elasticity of peripheral vessel. Deviation between systolic and diastolic pressure is pulse pressure, which might be held in definite level because from pulse pressure will depend activity, filtration of the blood for formation of primary urine, other word, functional activity of kidney. We distinguished basal pressure, which is pressure which is measured in complete relaxation of the patient. More optimal when the patient only opens the eyes, not gets up, and will immediately measure his pressure. And medium pressure. It is not average pressure. We are talking about medium pressure, which is pressure which may be held into the circulatory system without heart contraction. And it may be calculated depending on diastolic and pulse pressure. Why is it needed to know about medium pressure? Because again, I'll come back to its characteristic. Pressure which hold without heart contraction. Other word, it is a situation of clinical death. When no heart contraction, no pulse, no systolic pressure, but blood short time hold its circulation due to medium pressure. It hold our brain from early death and give time for emergency aid. Usually it's from 10 to 20 minutes, after which will be sometimes come back changing in inner organs and first of all in central nervous system, and if will come back consciousness of the patient, his life may be restricted due to decreased activity of the brain. I won't remember you physiological mechanism regulation of blood pressure. You studied the on normal and pathophysiology classes, but I want to remember some main principles. Blood pressure regulated with two mechanisms in our organism, hemodynamic and neurohumoral. Hemodynamic, there are first of all cardiac output, systolic pressure, and general peripheral resistance of vessels, diastolic pressure, which tightly correlated with elasticity of the peripheral vessels, blood viscosity, and volume circulated blood. Neurohumoral mechanism regulate resistance of peripheral vessels. You remember about renin-angiotensin system. Neurohumoral mechanism divided on two types depending on time activation. Fast short-term system, immediate response on any pathological process, and long-term exposure system which control blood pressure for usual life. If we are talking about fast short-term system neurohumoral regulation, first of all, I said you, it appears immediately as response on any acute situation. And control blood pressure during some seconds or during some hours. In immediate neurohumoral mechanism, first of all, there are pressure receptor mechanism, chemoreceptor mechanism, and ischemic reaction of the central nervous system. Then involve other regulative mechanism. We are talking about medium-term control. There are renin-angiotensin system, which is synthesis antidiuretic hormone, and capillary filtration as response on some problem with circulatory system or peripheral vessels. Long-term exposure neurohumoral mechanism. First of all, there are pressure renal volumetric mechanism and local renin-angiotensin system, because synthesis renin-angiotensin is a continuous process, but in some times its level suddenly increases. Regulation of the blood pressure tightly connected with condition of vessels endothelium, because they very fast response on any circulatory situation due to activity of pressure mechanism. And we must remember about the pressure mechanism, because normally synthesis of some enzymes regulated with opposite depressor mechanism, which include synthesis of prostaglandins, kallikrein-kinin system activity, factors of endothelium vasodilating, and synthesis of natriuretic peptides. And if both mechanism, pressor and depressor, correlated, will have usual, comfortable, normal blood pressure. This correlation of this mechanism manifested with increased or decreased blood pressure. You'll understand if pressure mechanism prevalent, blood pressure increased. If depressor, blood pressure decreased. Etiological factors, formation of arterial hypertension. No, first of all, endogenous, there are genetic factors which tightly correlated with exogenous effect, about which we said last lecture when we talk about etiology of angina pectoris. And again, you must understand, some problems may be regulated, other problems must be correlated. But again, exogenous factors have very high value for control of blood pressure. No, genetic factors, it is hereditary predisposition and which appear due to various genetic mutations. Exogenous factors, same as for ischemic heart diseases. It is obesity, it is hypodynamia, it is some social economic stage, predilection to psychological stress situation, some professional provoke factors, and arterial hypertension early appears of the patient with excess use table salt. Risk factors, no? First of all, age, then more elderly patients, then they more predilected to high blood pressure. Men early predilected to high blood pressure than women, but in some age period, risk factors becomes same activity. Because women more predilected to blood pressure problem after menopausal period, when the activity of estrogen progressively decreases, and ethnic factors, people with dark skin more early predilected to high blood pressure. Pathogenesis. Blood pressure increases due to increased activity, sympathoadrenal system, renin, angiotensin, aldosterone system, other words. I said you about increased activity pressure mechanism. When activity depressed factors decreases, decreased activity of kallikrein-kinin system and renal depressor function. Plus endothelium dysfunction, non-adequate response on any situation, and we have patient with high blood pressure. Arterial hypertension classified depending its origin. And we are talking about essential hypertension when the primary pathology into the heart activity. And symptomatic secondary arterial hypertension, which appears as complication, you see such more mechanism involved in control blood pressure. But very difficult to differentiate each is primary essential or each is symptomatic hypertension, because later you will see that long-standing hypertension involved in pathological process in organs, and very difficult to decide primary problem with kidney was provoked factors of hypertension, or arterial hypertension provokes pathology of kidney. Secondary symptomatic arterial hypertension divided on some subtypes. Depending level blood pressure. If more significant increase systolic blood pressure, we are talking about systolic hypertension. If both systole diastolic, more often we'll meet with combined systole diastolic arterial hypertension, but some diseases characterized only with high systolic blood pressure. We said with you about heart defect, aortic insufficiency. We will talk with you later about thyrotoxicosis and atherosclerosis of aorta. This pathology characterized with more high systolic blood pressure and classified as systolic arterial hypertension, which needed specific correlation. Combined systole diastolic with predilection diastolic blood pressure. There are renal etiology hypertension, some endocrine diseases as adrenal gland problem, acromegaly, hypothyroidism. And we must remember about some problem with alcohol. Some medicines has a complication because disturbed blood pressure, and alcoholism because it's complicated with very lot different pathology. Classification arterial hypertension is needed to prescribe the patient more optimal treatment, because on pharmacology you will study lot of hypotensive medicines. We'll distinguish main 5 groups of hypertensive medicine, but some medicine more effective for one or other types of arterial hypertension. Patient with arterial hypertension, clinically in diagnosis it's obligatory to show it, classified depending on level of blood pressure. And I'll again pay your attention. We distinguish normal blood pressure, systolic less than 130, diastolic 85. Not mixed with optimal blood pressure, which is characterized only with one level, 120 and 80. Optimal, I remember you, it is pressure which comfortable for lot peoples, but not obligatory that everybody has pressure 120 to 80. It may vary, but we'll pay attention when it becomes higher than 130 and 85, and again distinguish body level of pressure, high normal, which needed attention for this patient, but will prescribe medicine depending on some factors. And first of all, we'll pay attention on age of patient, his height and weight. And if you record pressure 135 to 85 for the woman with 65 years old with slightly increased weight, it may be not needed decrease. But if such pressure revealed in a thinning woman 20 years, we must examine her completely to exclude provoked factors of arterial hypertension. And all pressure above 139 from 140 to 159 assessed as hypertension first degree. From 160 to 179 second degree. Higher than 180 third degree. And if we reveal only high AP systolic and normal diastolic, we are talking about isolated systolic arterial hypertension. Why we'll classify arterial hypertension on some degree? Because depending degree, will dependent activity of therapeutic measures. And hypertension fourth degree may be controlled with one medicine. From second degree, will prescribe minimally 2 medicines, and third degree needed more wide and active therapy. Isolated, I said you systolic arterial hypertension may be corrected with specific drugs. Arterial hypertension obligatory classified on stages which depend from the affection of touched organs. I said you, if you remember, that arterial hypertension, long-standing high blood pressure, obligatory effect in organs. And we distinguish organs with first of all involved in pathological process. There are touched organs, and first of all, central nervous system, obligatory heart because it's work with high activity, kidney, fundus oculi, and peripheral vessels. And depending involvement and activity affection of these organs, we distinguish stages of arterial hypertension, which also assess for correct treatment and for assessment vital activity of the patient. We are talking about fourth stage, when we reveal high blood pressure but touches organs without affection. Ultrasound examination of the heart without pathology. Examination of kidney, no problem. Fundus oculi, all right. Peripheral vessels not affected. It's more early, more soft development of arterial hypertension. First stage, only high blood pressure. Second stage, we'll see involvement of touched organ, but without functional abnormalities. For example, we'll reveal hypertrophy of the left ventricle, but its contractive ability holds no signs of heart failure. We reveal changes of the vessels fundus oculi, narrowing of arteries, but no affection of vision. We'll reveal some pathological indices in urinalysis, and level of serum creatinine will be high level or slightly increased, but no significant dysfunction of kidney. And third stage, when the affection of touched organs complicated with functional abnormalities, other words, with some failure. If heart will be different degree of the heart failure, or in anamnesis myocardial infarction, which appears later than was recorded high blood pressure, because high blood pressure was provoked factors of myocardial infarction. If central nervous system was transient disordered cerebral circulation in anamnesis or true brain stroke inside, we can reveal signs of hypertensive encephalopathy when the psychic adequacy of the patient disturbed, or we can reveal chronic hypertensive encephalopathy. From kidney, signs of renal insufficiency when the level creatinine in men becomes more than 133 micromole per liter, for women slightly lower, 124 micromole per liter. Fundus oculi, problem with vessels complicated with hemorrhage into the retina due to rupture of vein. Some spots of dystrophy due to significant constriction of arteries. As a result, we can reveal problem with papilla as edema or retinal detachment, which is grave complication of arterial hypertension because patient progressively loses vision and sometimes can lose completely. You can compare normal fundus oculi and affected, very difficultly visible arteries because they narrow it as a result due to disturbed nutrition, dystrophic foci, and hemorrhage due to rupture of dilated veins. Peripheral vessels will be revealed aneurysm of aorta or involvement of peripheral vessel due to progressive atherosclerosis, clinically manifested with difficulty healing wounds or sometimes with gangrene lower extremity. Clinical picture depends from the time and level blood pressure. Early stage, when the blood pressure increases periodically and insignificantly, maybe some neurotic disorders, such as weakness, impaired work capacity, inability to concentrate attention during work, deranged sleep, transient headache because high blood pressure, sometimes feeling of heaviness in the head. Other words, some discomfort which provoke doctor's examination, and in this situation we'll start our examination from measuring blood pressure, and if we'll reveal high blood pressure, we are talking about arterial hypertension. Usually it's not significantly increases and periodically, and very difficult to explain the patient during this period about needed medicines correction, because if periodic patient decide, I'll remove this problem independently, because everybody are afraid long-standing drugs treatment, no, and it's difficult. Sometimes high blood pressure instead headache accompanied with palpitation or disordered heart rhythm. Early stage. For diagnosis, you see as rich examination. No, first of all, we'll measure blood pressure. It's high. We'll auscultate heart to reveal some specific indices of high blood pressure. We'll obligatory send our patient on blood and urinalysis together with specific Nichiparenko test and creatinine to reveal problem with kidney, because high blood pressure may be complication preceded chronic kidney diseases such as glomerular or pyelonephritis or other kidney diseases. We'll examine level of microelements, potassium, sodium, to reveal some endocrine disorders. We'll control blood sugar, because diabetes mellitus is provoked factors of hypertension. will obligatory send our patient on electrocardiogram and ultrasonography and examine fundus oculi. Because depending on blood pressure will determine degree, depending of other examination will determine stage, because we'll examine all target organs. Objective examination. No, first of all, it is high blood pressure. I pay your attention, will distinguish normal and high normal. If above high normal, no problems, it's arterial hypertension. Then, examination of cardiovascular system. From the second stage will reveal hypertrophy of the left ventricle as compensatory response on more high contraction because it must push blood in high blood pressure. As a result, will be displayed apex beat and it becomes high and diffuse. After some time, we can reveal X and second sound over aorta, and peripheral pulse on radial artery becomes firm and tense. There are cardiovascular indices, arterial hypertension, because on exam will be question specific examination of the patient with hypertensive syndrome. On ACG, will reveal signs hypertrophy of the left ventricle, deep S-wave insert standard lead, accompanied with high R-wave first standard lead and high R-wave in 5-6 checked leads, which indicate overloading left ventricle. I want to pay your attention on some acute situation. Hypertensive stroke. It is characterized with sudden increased blood pressure, accompanied with appearance increase in cerebral, coronary, and renal circulation disorders, and also pronounced vegetative nervous system functional abnormality. Why we distinguished acute situation hypertension stroke? Because it needed our emergency aid. We must decrease pressure during short time, because you see it's characterized with disordered circulation of the main vital organs and will afraid acute situation due to disordered cerebral, brain stroke, coronary, myocardial infarction, kidney acute renal failure, and acute loss of vision. Usual development arterial hypertension. Pressure regulated during definite period will not suddenly decrease blood pressure. Will give initial medicine, then gradually increase them before definite comfortable level, then can slightly decrease or hold on definite level. Hypertension stroke, blood pressure must be decreased during short time to prevent acute heavy complications. How can we know about hypertension stroke? First of all, very severe, sharp headache, which accompanied with giddiness. Sometimes patient can lose consciousness or will be some disorientation. Pain in the heart region accompanied with palpitation or disordered rhythm. Headache accompanied with nausea and vomiting without positive effect, which showed its central origin. Maybe some problem with vision, bad vision, or some subjects becomes twice. And may accompany it with severe perspiration. No, it's result activity of vegetative nervous system. On objective examination, patient excited, haunted by fears, or maybe opposite, indifferent or somnolent. Sometimes I say you maybe a loss of consciousness, but usually it indicates about early heavy complication brain stroke. And I'll pay your attention, not depending of clinical symptoms. Systolic blood pressure above 240, diastolic 140 must be estimated as hypertension stroke and needed emergency aid. Not dependent from symptoms. Some patient doesn't feel any discomfort, which is casual variant, or can feel only some headache. He's seen about usual development of blood pressure, will measure pressure 240 or 140 for diastolic. It immediately estimated as hypertension stroke. Patient needed hospitalization because blood pressure must be decreased and controlled only in stationary state. Ambulance control impossible because will afraid severe complication which can significantly disturb vital activity of the patient. From the heart, which is myocardial infarction or acute left ventricular failure, both situations may finish with death. Brain stroke for central nervous system. Acute dissecting aorta aneurysm also may be finished with immediate death of the patient. Acute hypertensive encephalopathy. Different types of arrhythmia, paroxysmal tachycardia, atrial flutter fibrillation, more grave ventricular flutter fibrillation. Eclampsia, which usually appears in the pregnant woman final period, and different bleeding due to rupture of peripheral vessel. And to prevent these grave complications, will obligatory hospitalizate patient in specific cardiovascular or therapeutic department, decrease blood pressure during short period, usually during 2 hours, and then control his objective state with instrumental and laboratory examination. These manipulations are needed to prevent any grave complication and death of patient and hold vital activity of patient. Now, to control yourself, you can see on this task your patient with headache, feeling heaviness, vertigo, noise. Objectively will reveal high blood pressure and hypertrophy of left ventricle. About what stage do you see? If you think about second stage, you are right. Next situation. Again, patient have some symptoms which indicate about disordered blood pressure, in anamnesis myocardial infarction, and also blood pressure with hypertrophied left ventricle. It will be assessed as a third stage because we see functional heart problem, myocardial infarction in anamnesis. All next period, not depending from other symptoms, will show third stage arterial hypertension. That's all today. Thank you for your attention. I think that this information helps you for practical classes. Goodbye, be healthy. Да, я слушаю, что про интернет. Ну, если когда вы переслали? Сегодня? Ну, вчера вечером нет, не смотрела, а вы на Вайбер переслали. А днем у меня в телефоне нет интернета. То есть я приду домой, тогда гляну. Да. Ну, давайте где-то я через часок буду дома. Перезвоните мне, да, то я могу просто замотаться, да, чтобы не забыла. Через часок перезвони. Ну, где-то вот сейчас сколько у нас? 2 часа, около 2. Давайте часа где-то в 3, да, вот так перезвонить, потому что потом я опять уйду. Вот, где-то с 3 до 4, хорошо, я посмотрю, и мы с вами побеседуем. Да. Какой-то дискомфортик есть, да? Ну, конечно, вы же провоцируете свой рефлекс. Ну хорошо, давайте я приду домой, посмотрю, мы с вами поговорим. Мгм. Хорошо, хорошо. Да, да.